So this morning we have Dr. Adam Numis. He's the Associate Professor of Neurology and Pediatrics at UCSF Benioff Children's Hospitals. Welcome, Dr. Numis.
Thanks, everybody. Thank you. And thanks for allowing me to speak. So today they asked me to talk about epilepsy basics, but I feel like most of the people in this room know a little bit more about epilepsy than just the basics. So we're going to introduce the terms that you probably hear all the time, but then delve into it a little bit more. And this is totally informal, so if questions come up, interrupt me, yell, raise your hand, whatever you want to do. This is meant to be very interactive. And no one's paying for this, so nothing is being influenced by pharmaceutical companies or anything like that. So what we're going to try to do, talk a little bit about seizures, what the terms mean, what EEGs are, what they actually tell us, different types of treatments for seizures, and then getting into some of the things we need to know for schools when you're interacting with your school systems. So just basic, right? Seizures versus epilepsy, right? What's the difference? A seizure is a single event where your brain has an excess amount of electrical activity. Epilepsy is when you have two or more of these seizures that are not caused by low blood sugar, high fevers, things like that. So the difference between epilepsy and a seizure, right? Epilepsy is when you have two of these unprovoked seizures. Again, not related to a really low blood sugar, not related to an adult's alcohol or drug use, things we don't worry about in kids too much. So that's the big difference. Epidemiology is the study of how, at a population level, sort of how many people really have something. And if you look across the United States, it's about 1% of patients, or people, 1% of people in the United States have epilepsy. About 5% of people will have a single seizure in their lifetime. 1% of people, a little bit more than that, will have a diagnosis of epilepsy. It's most common in this little figure. Age is on this x-axis. Y is the number of people. You can see it's more common to get diagnosed with epilepsy in your first few years of life and then later on in adulthood. The reason for that in later adulthood, it's related to strokes and trauma, things we don't see as much in kids. But certainly we know that seizures and epilepsy are more likely to occur the younger you are. And then there's this relatively quiet period in your early adulthood, mid-adulthood, where it's not diagnosed as much. Again, so epilepsy in adults, really we're talking about things like stroke, brain tumors, infection. In kids, it's a lot more varied. So there's lots of different diagnoses. We're talking about hundreds and hundreds of different things that could potentially cause epilepsy, which makes it exciting and challenging at the same time. Challenging for families and practitioners, but also exciting in terms of we can come up with better precision therapies than we can if we're just talking about one or two different things. So it's a lot of room for improvement that we can do when we're talking about what are these different things that could potentially cause it. And so trying to create not a one fit for all kind of thing, but really trying to narrow down and trying to target therapies for particular patients and their families. You've probably heard of some of these terms. They keep on changing. So these are lots of different syndromes. We kind of try to think of them as, is this something that might be easier to treat? Is this something that might be harder to treat? And that helps us try to figure out where someone may best be treated, right? Is this someone that could be seen by a child neurologist, an epileptologist, and we'll get into the difference between that. You might also wonder, right, why does my child's diagnosis change every few years? This is as frustrating for you as it is for us. What happens is every 5 to 10 years, a group of people, their names are here, some of them gave talks yesterday, they get in a room together and they decide, okay, well, let's see what makes sense, what doesn't make sense, how are we going to change these names? So for example, Rolandic epilepsy is no longer called Rolandic epilepsy. Now the name is self-limited epilepsy with central temporal spike. So things are constantly changing every 5 to 10 years. It's okay to use any term that you've ever heard, right? We all understand it. We're still trying to adapt to this new sort of terminology. And again, it's meant to try to help foster sort of a similar dialogue between everybody. What's lacking from these groups are patient advocacy groups, right? And I'm hopeful that the next time they do this, they actually involve patients and their families. There's a push to actually do this. So rather than just having, 15 neurologists and epileptologists, they actually include families, right? Because it's important that we hear your voices. Because these names, you can put whatever label you want, right? It's just important that we're using the same language, and it's important that we have parents and families involved in these conversations, which again, 5 to 10 years when we do this again, hopefully that's what we wind up doing. If I'm on it, I will make sure we have patient advocacy groups on there. So how do we classify and categorize seizures? So think about it, when we're trying to come up with a diagnosis or a cause for epilepsy, there's a few different things that we're going to look at. One is, when did they start, right? There's a difference between a baby having seizures, an infant, and early childhood, a late childhood. So the age at which it starts really gives us a lot of guidance as to what kind of diagnoses or treatments we might have available. The type of seizure, too. Again, names change, right? So things that we used to call partial seizures or complex partial seizures, those also change every 5 to 10 years from the same group of people. So if it's confusing for you, it's also confusing for us. But whatever words you're using, we'll understand them. But you'll see different people use different words. It's not that the seizures are different, it's just that the terminology changes every now and again, and pretty much every 5 to 10 years. So again, hopefully as we do this on the next reiteration, we involve parent advocacy groups so they have some say in sort of when these names are changed so that we are all communicating the same way and it gets less confusing. But just in general, seizures, tonic seizures are basically a stiffening seizure, right? Clonic seizures are when there's a jerking movement. Myoclonic seizures are sort of like a rapid kind of movement of your body. So if you're sleeping or you know somebody or you've been around somebody who sleeps and they kick, that's a myoclonic jerk, right? It's not epilepsy, it's just that's the kind of movement we can see. So it can either be epileptic or non-epileptic. And then there's other seizure types. Again, absence seizures, what we used to call complex partial, which are now focal with impaired awareness. Again, the names are going to continue to change. The seizures are the same. What we call them are different. So confusing, I know. We also use EEGs, right? So EEGs are super important. We're going to go over what they actually measure. And then how someone's developing also helps us understand, right? Are they developing along their track? Have they kind of plateaued? Are they having some difficulties in school? Or have things sort of taken a turn for the worse? All these things kind of help us. And help guides what we're going to do, right? Not everyone needs a ton of lab testing. Not everyone needs an MRI necessarily. Not everyone needs a ton of different tests, right? It really depends on what kind of epilepsy diagnosis we're talking about. Again, these used to be how we called seizures and described them, right? Complex partial, simple partial, all of those things. This is now what it is. I just want you to know, right? The names are going to keep on changing. Now, again, complex partial or focal with impaired awareness. This is 2017, so we're probably up for an update in a couple of years. But this is really what we have to look at. So this is like the abbreviated version. This is the detailed version. So there's a lot to it. And again, if you don't remember, it's fine. It will change in a few years. So just grain of salt with everything. EEGs are important, right? A lot of kids with epilepsy, one of the first things that we do, right? There might be some lab testing to make sure your blood sugar's okay. But EEGs are really how we help diagnose this and really help guide our treatment and management. And I think everyone in this room is probably familiar with having an EEG placed, but I think the history is kind of pretty cool. So EEGs were first developed in the early 1900s. They were putting electrodes on mouse and rats just to see, right? They really didn't know what they were looking at the time. And then Dr. Berger, Hans Berger, German psychiatrist, right? There weren't neurologists back then. Everyone was a psychiatrist. In the 1920s, moved those electrodes from mice and rats and put them on his son. And so this is the first EEG that was done, just a couple different electrodes, and he placed it on. You can't do that anymore. There was institutional group wars where you can't do research like that. But he put it on his son, and that's how they did it. And with that technology, it quickly blossomed. People really kind of figured out, okay, this is actually something we can utilize and help, right? It's not like epilepsy has changed in terms of how many people have it. It's always been about 1 to 2% of the population. And so epilepsy was common then, it's common now. And so people quickly realized they can use this to try and understand how the epileptic brain talks, how we can listen to it, and how we can help kind of figure out what the next steps are. These are some other names in terms of people in the 30s. It really got picked up, and we tried to figure out what's normal, what's not normal. What is a epileptiform discharge or a spike, which we'll talk about. In the 1960s, it really kind of took off, and we tried to figure out how we can use this technology to do management kind of paradigms. Has anyone been in an epilepsy monitoring unit or hospitalized overnight? Yeah, so that technology came out in like the 90s. So before that, we had paper EEGs, right? The digital stuff didn't work. And so you had these pieces of paper that's constantly, the amount of paper that was wasted. That's how you did it, right? And it was very difficult to do. And then with digitization of EEGs in the early 2000s, epilepsy monitoring units became a thing, and we can actually do these kinds of tests for more than just 20, 30 minutes, right? So there are still some rooms in hospitals or hospital basements. I'm at University of California, San Francisco, so this is off-site. There's like an entire warehouse of paper EEGs, right? It's that much paper that was utilized for some of these things. So what are we actually measuring, right? So what is that little sensor actually looking at? And you're not measuring sort of the signal transition. You're not measuring the actual electrical activity going through an axon, going through a neuron. We're not measuring that. And that's kind of what a lot of people, including doctors, will think. An EEG electrode's up top here is your skull, and inside, right, you have thousands, millions, billions of neurons, right? And they're all kind of communicating to each other and talking to each other. So that sensor isn't measuring what's happening inside that neuron. What it is measuring is as those signals are going from one neuron to another and transferring throughout the brain, there's a lot of different signal changes that occur. So you have ions, positive ions, negative ions, that are constantly kind of circulating. And so what we're measuring is the changes in ions, changes in salts, essentially, changes in positivity and negativity. And as the brain cell, as those neurons communicate, those currents kind of change. And so again, we're not measuring what's happening inside the cell. To do that, you need like a needle that goes, a very, very thin needle that goes into a neuron, which we don't do. What we're actually measuring is just how those currents are kind of changing. And so we really, when you think about it, EEG can't tell you the exact precise location of something often. It gives you a general idea, and this is why. We're not measuring individual neurons, we're measuring large changes in how those ions, those positive and negative kind of ions, are changing over time. What EEGs do help us, they give us a very good temporal signature of things, right? We can say exactly when a seizure starts, exactly when a seizure stops. But sometimes it's not possible to really dig down and say, okay, exactly what area it is. Sometimes it is, if it's just a small collection of neurons that are causing a seizure. Often, though, it can be a larger area, and that's, again, why it can be frustrating, right? You want to know exactly where something's coming from. EEGs do have that limitation. And that's why sometimes when we're trying to think about things, we sometimes have to put things inside the brain to really get a better way to listen to it. How do we see it, right? So you have that sensor detecting all these changes in ions, changes in currents, right? There's a series of wires, right? You guys are familiar with this. And then there's a ton of electronic engineering that went into changing those signals from a paper recording to actual digitalization, right? So a ton of different engineering that gets into this. This is a schematic that we could spend like an hour on. What's cool is all of that technology is in that little box. So that little box, which is like $60,000 a pop, that's what does all of that digitalization. Takes that recording, filters out all the noise, right? Filters out all the electromagnetism of the earth, right? Right now we're standing, there's a ton of electrical magnetism that comes just from the earth moving. And so we need to filter that out as well. We need to filter out the current. So the wires in the wall communicate with electricity, just like our axons, our neurons, right? And so we have to filter out all that electrical noise that's coming from there as well. So this box does all of these crazy different things in there. $60,000. And you get that. That's before inflation. I don't know what it is now. And then we get to see what we're looking at there. Now, there's a reason the electrodes are put on particular locations on the head. We kind of standardized this back in the 40s and 50s so that we knew exactly where things could be located. That way, if I'm talking to someone or colleagues at Los Angeles, Colorado, East Coast, we all are using the same kind of language, same kind of words. So that's why they do that measurement every time. That's why they're really trying to target the exact precise location so that we can communicate both within ourselves over time and we can talk to other people and to you about where and what things are looking like. This is just other. You can put them anywhere you want, right? It's just by convention we do this so we can communicate with everyone. When you put it all together, you get all these waves, right? And you guys may have seen these as these are happening, right? But this is what an EEG looks like. Now, those two lines, basically, you're measuring the difference between the electrical signals between two electrodes. That's what each of those lines is looking at. When we do this, you can filter this and move it around however you want, right? So you can put these lines in whatever organization you'd like. By convention, we often will put them in a particular way so that we can visually know what we're looking at over and over and over again. What are we looking for in an EEG, right? We're looking for more than just seizures, right? We really are also looking at how the different parts of the brain are talking with each other. So we're looking at the frontal part of the brain. How is it interacting with the back part of the brain? How is the left communicating with the right? All of those things are important. So we're looking at whether someone's asleep. We can tell all of those things on our EEG. We're also going to make sure those signals are kind of continuous, right? In a newborn baby, they aren't. You have periods where your brain is kind of bursting and excited, and then periods where it's very quiet. As you get to 1, 2, 3 months of age, it becomes more continuous, and you have electrical activity that's pretty much happening all the time. We're looking at how many of those squiggly lines are happening a second. That's an important part of everything, too. How big those waves are is important. And then we get into the thing that a lot of people will talk about are paroxysmal abnormalities, which are spikes, sharps, things you probably have heard about. What those are essentially are collections of neurons that are basically just crazy too active, and they basically cause a short circuit. So think of it again the same way wiring in the walls we're all familiar with. If you have short circuits in the walls, you'd be able to eventually kind of know something's happening and that something's wrong. EEGs are telling us things that we can't necessarily see, right? With electrical outlets, if you plug it in and it's not working, you know there's some sort of short circuit or something's happening there. That's not necessarily what happens in people, right? So the EEGs can help us understand exactly what's happening in the brain. So those short circuits or spike wave discharges are collections of neurons that are just hyperactive, way too active, and have these extra bursts of electrical activity. Seizures are basically when those short circuits start to become rhythmic and happen over and over and over again. So again, think of it as wiring in the wall, right? If there's a lot of short circuits happening, you're at much higher risk of having an electrical fire. In someone's brain, if you're having a lot of these short circuits, you're at higher risk of those short circuits becoming rhythmic and starting to cause a problem, which we call a seizure. So seizures themselves are collections of these rhythmic discharges, rhythmic extra short circuits that happen and have a beginning, a middle, and an end. And so seizures, again, by definition, we think that they should last at least 10 seconds in duration. So when these extra short circuits start happening over and over and over again, it's kind of like they build and build and build and gather friends to kind of talk with them. And that's how you get these seizures that can start in one location and then gradually spread throughout the brain, or rapidly spread throughout the brain, even to the other side. And again, what they do is they can kind of recruit neighboring and close by neurons that aren't typically having these extra bursts of electrical activity, and they kind of bring them along and they say, come on, let's go. We're all going to synchronize and do this. And so that's what a seizure is. Do you need an MRI? Often, yes. But for kids where we diagnose something like absence seizures, right, childhood absence epilepsy, it's about 25% of kids who are diagnosed with epilepsy will have that diagnosis. That's where the whole brain is sort of short-circuiting. We know that those kids don't need MRIs. MRIs are really helpful for detecting areas of the brain that might have developed differently. Brain tumor is very uncommon. Strokes, also very uncommon in kids. So these are the things we're looking for in an MRI. In someone who has a generalized epilepsy where the whole brain is kind of short-circuiting, MRIs aren't helpful. It's a test that often requires sedation in younger kids. It's an expensive test and doesn't give us any additional information, more than what an EEG can offer. In people who have Rolandic epilepsy, which is now, again, self-limited epilepsy with central temporal spikes, or SELECTS is the acronym people are using, that is another diagnosis where the MRI has never been helpful for us. We know that those kids, that's what they have. We know what the trajectory is. They often outgrow it. That accounts for about 20% of childhood epilepsies. So in about about a third of kids who are diagnosed with epilepsy, an MRI is not always necessary. So it really depends on what kind of information we're gathering from someone's history, what parents are telling us and describing, and then what our EEG is telling us. So really it's an EEG that's our first step. And then depending on what we find, an MRI is sort of what we're looking at next. MRIs come in lots of different flavors, so it's important when you are getting an MRI, you hopefully only want to do it once, right? I've had them. If anyone's had one, they're not particularly exciting or fun to do. You're going in a narrow little tube. It's a big ask for anyone, adults or kids. If you're under 7, 8, you definitely need sedation. There's tons of adults, I think, that could also benefit from sedation for MRIs. It's just, it is a big deal. And if you're doing an MRI, you want to make sure you're doing the right one. So they come in different strengths. The higher the strength of an MRI, the more likely you are to detect kind of subtle different changes in your brain and the way it may have developed, which might be a reason why you're having seizures. So you'll hear things like 1.5T, 3T. Those are just the strengths of the magnets. Most of the time for patients with epilepsy, we're using 3T MRIs, and it's just important to make sure that that's what you're looking at. That gives us the best description of sort of what we're looking at in the brain. There's higher strength MRIs, 7 Tesla. Those are more of a research at this point, done on research. They can give you very detailed images, but the strength of the magnet is such that they actually are very uncomfortable. And a lot of people do need, if you do them, need some sort of sedation with it. It actually makes you shake. The strength of the magnet is so high that people actually will feel themselves vibrating in the magnet. So it's a very uncomfortable thing. We don't like to do them. It's really a research thing. I'm not sure how widely adopted it will be. 3T MRIs are pretty much standard now. That's totally fine. You don't shake, you don't vibrate. It's just annoying to be in a small tube, right? And again, sedation, pluses and minuses, right? It's important if you need to do this study, but you don't want to give people sedation just to do it, right? And that's why repeat MRIs, you really have to be cognizant of Do I want another MRI? What additional information is it really going to provide me? What additional information is it going to give my provider or myself? And if the answer is nothing, then you don't want to just do these, right? Again, it's a stress on the body, it's a stress on the system. The sedation we use for MRI will typically calm seizures down. So it's important to know, MRIs themselves, while stressful, you can see an uptick in seizures before the MRI, just because of the stress that's associated with it. The MRI itself, if you're using sedation, actually quiets the brain down and suppresses some of that extracellular activity we were talking about. Another common question, right? So we were talking about different tests, right? EEGs, that's our gold standard. Everyone needs that. MRIs, more likely than not, you will need one. After your first seizure, do you need genetic testing? And I think this is where we're moving forward with things. In terms of different types of genetic testing, these are the sort of plate of options we have available to us. In my practice, we will offer genetic testing on anyone who has epilepsy, who's failed at least one medication. And genetic testing can help us understand what kind of epilepsy someone might have. It can help us figure out, okay, well, if there's other kids or adults with this particular type of genetic change, what does their epilepsy look like? Do they outgrow it? Are there particular medications that help? Are there other medications that don't help? It also helps, if we find an answer, it's a really nice way to get into different patient communities, right? With a particular genetic diagnosis, there's lots of different forums, and patients and families can get plugged in to families who are experiencing very similar types of things. So it's important for a lot of different reasons. One day, I'm sure we'll do this on everybody. At the moment, it's just a little bit tough with insurance. Interestingly enough, genetic testing costs way less than an MRI. An MRI, depending where you are, is like $3,000 to $6,000. Genetic testing, this test is $40. My parking in San Francisco is getting close to that right now. A gene panel is about $100. A whole exome, about $1,000 once you include all the different technology and bioinformatics that go into it. So these tests are actually much cheaper. Even though insurance makes you go through giant hoops often to get these done, I cannot explain why. I do not try to understand the insurance field whatsoever, because it would make your mind blow up. If anyone's in insurance and you can explain this to me, I would love to hear it. Because I don't understand why these tests, which can be so helpful, right? I was saying MRI is not always helpful in patients with epilepsy. These tests can be super helpful. Insurances deny them, even though they're a fraction of the cost of the MRIs. Hopefully this changes in the next 5 to 10 years. I'm hopeful. It's a lot better now than it was a decade ago, so we're getting there. In terms of what these different tests are, so I think of the way I think about DNA. DNA is a book, right? And all of us get 2 different pages, one from our mom, one from our dad. And our book has 26 chromosomes, so 26 pages, all undo, one copy from mom, one copy of dad. So you have 2 page 1s, 2 page 2s, 2 page 3s, right? An epilepsy gene panel is the most common test that's used. This gives us an answer in about 20 to 30% of patients, depending on what kind of epilepsy you have. So it can be really helpful in sort of diagnosing things. It can be really helpful in kind of understanding what might be contributing to someone's epilepsy. What this says is, okay, well, we know there's about 200 different genes that are associated with epilepsy at this point. Right now, I think it's about 220. So what we do is we take those 220 genes. So we say, okay, well, on page 2, paragraph 3, line 4, word 5, that's an epilepsy gene. We're going to spell it out and make sure it's spelled correctly. If it's not spelled correctly, then it's going to be something that we think could be associated with epilepsy. The other thing that can happen is it's spelled correctly, right? That's fine. Or it could have a spelling change that doesn't really change the meaning of the word. And that's called a variant of uncertain significance. And so you might have heard this term in your reports. All that means is we don't know enough about it yet. So one way I think about it is, that there's some words in English, American English and British English, that are spelled differently. It means the same thing, but they're just spelled a little differently. And so you can have words like that where they're spelled a little differently but mean the same thing depending on where you are. There's other spelling changes that look like there and there, right? T-H-E-R-E and T-H-E-I-R. Look very similar, mean very different things, right? I still have a tough time getting the difference correct. But that's what epilepsy gene panels are looking for. So you have a finding that's spelled correctly, incorrectly, or that in between gray zone. Whole exomes look at more than just the 220 genes associated with epilepsy. They look at your entire genome. They look at so an exome is the parts of the DNA that encode proteins. So the exome is all of the parts of the DNA which actually make proteins. If you guys had to guess, how much of your DNA do you think contributes to that? It's 1%. Only 1% of your DNA actually tells your body how to make proteins. The rest, we don't know what it does. We have a lot of work to do. So the whole exome is measuring all of that 1%. So instead of just looking at the epilepsy genes, it's looking at all of those genes. Now at this point, we think we've found most of the genes that we think may be associated with epilepsy. We don't know all of them, and that's why whole exomes can be important if the gene panels are not helpful and the microarrays are not helpful. Whole exomes can sometimes identify genes that we aren't quite sure are associated with epilepsy, but again, it's adding and looking at the entire book. It often will give us answers that we're not sure of because we're looking at so many different words. A microarray is another important test. So the epilepsy gene panel gives us an answer about 20 to 30% of the time. A microarray gives us an answer about 5 to 10% of the time. What a microarray is doing is it's not looking at particular words, it's looking to see if the words are duplicated. So you can imagine if you have 2 pages of everything, they're spelled correctly, great. What if you have double the amount of pages you have, right? Let's say you have, instead of 2-page ones, you have 4-page ones. You got 2 copies from mom, 2 copies from dad, or 2 copies from mom, 1 copy from dad, right? If you have those duplications and everything's spelled correctly, it will say fine. The epilepsy gene panel and the whole exome are going to say, well, this is spelled correctly. But that duplication can be problematic. Same thing if you just have 1 page, right? Instead of getting 1 from mom, 1 from dad, you just get 1 from mom or 1 from dad, and you're missing a copy, right? The whole exome and the gene panel are going to say, well, it's spelled correctly, it's all good. But it's not, right? And so a microarray is looking at duplications or deletions of those pages. And so they're complementary tests. A whole genome, we don't really know what we're doing quite yet. This is a test. Again, we're measuring now not just the 1% of DNA that encodes proteins or tells our body how to build itself, but the 99% of the DNA that we think controls how those expressions are changing. We are relatively new in this. I think it's another 5 to 10 years before we really understand what we're doing with this. People have looked, if all of these come back negative, does a whole genome add anything? At this point, not really, because we don't know what we're looking for. In cancer, they've done a much better job over the last decade of doing whole genomes on everyone. And so they have a much better idea of, okay, well, what are the different parts of the genome, the intronic DNA between those between the exonic DNA that kind of regulate or tell a gene, like a neuron, how to be formed. We're not quite there. It doesn't mean we shouldn't be doing them, because if we don't do them, we'll never get the answers. But it just means if you do get a whole genome, if it's not giving you an answer right now, it doesn't mean it won't in 2 years or 4 years. So if you do get a whole genome test, it's important to ask them to re-look at it every 2 years. So re-examine it every 2 years. Once you do it, right? You have all the DNA. You looked at all the DNA. What the difference will be is, what do we know about it? Do we now know what those extra parts of the DNA that control the expression of the genes that are associated with neurons or their helper cells? So that's where you don't have to keep on doing it, you just have to keep on asking them to look at it again. Because again, our knowledge of what different parts of the DNA regulate how neurons are changing or signals are transducing will keep on getting better and better and better. So even though it may not be as helpful right now, it doesn't mean it won't be helpful in 2 years, 4 years, 6 years, 8 years, 10 years, right? Same thing with whole exomes. A decade ago, we really didn't know what we were doing. There was like 10 genes that we knew were associated with epilepsy. Now, we're over 200, right? So the whole genome will be really important. It's just if you don't get an answer right now, it doesn't mean you won't get an answer in a couple of years. You just got to keep on looking at it. And then this is kind of where I come in sort of the research-based testing, where we look at different types of genetic testing, sort of second generation, third generation kind of test, to try and help understand not just how your DNA is spelled, but also what happens between your DNA and getting a protein. Right? So there's a whole process of your DNA might be spelled correctly, but the protein just doesn't come out the way we want it to. And so that in-between process is kind of what we're looking at in my lab and trying to understand where that process can go awry and how that might influence epilepsy and what's changing. So who should you see, right? You might have child neurologists are neurologists who specialize in neurology, and just to get a sense of people's training, right? So after medical school, a child neurologist spends 2 years doing pediatrics, 1 year of doing adult neurology, and then 2 years doing pediatric neurology. Often a child neurologist can be very helpful, especially if it's one of the epilepsies we talked about earlier that 45% of children have that often will respond to your first medication. A pediatric epileptologist is a child neurologist who then spend another year or 2 just focusing on treating and managing kids with epilepsy. So those are the differences. Again, in some places you can't access a pediatric epileptologist. We're in California, where there's more epileptologists than most countries, right? There's some states that don't have any pediatric epileptologists. There's some states that don't have any child neurologists. So it really depends on your location, where you are. I think Zoom-based visits have been fantastic. In San Francisco, we've been using them even before the pandemic. Zoom, we started doing, in San Francisco, it's a broad area. California is big, Mountain West is very large, right? And so Zoom was actually started about 11 years ago for adult stroke victims. So adults with strokes, they figured out they can't, if they can't move, they can't get to their appointments. And so in San Francisco, they started this Zoom-based process. And so insurances weren't covering it at first, and then they eventually started covering it after a lot of mean letters that we all were writing in San Francisco. And we then were able to adopt it more broadly to other fields. And it's been a game changer for us, right? So even before the pandemic, if people were driving more than an hour and a half and they wanted to do a Zoom visit, fantastic. I don't like driving. I don't think most people like commuting, right? Some people do. I don't. Most people don't. And so why do that? If we can do a Zoom-based visit, that's totally fine. I mean, certainly there are times where you need to see somebody in person, and it's nice to have that one-on-one interaction and examine somebody. But oftentimes we can do Zoom-based visits, and that's helpful and can be enough. The type of center can matter as well. So epilepsy centers are centers with pediatric epileptologists that have particular expertise in surgical management, expert training, and different anti-seizure medications, maybe participating in research trials. So epilepsy centers are important as well. Again, not every patient with a seizure needs to be seen by a pediatric epilepsy specialist. Eventually, we will get to the point where we've trained enough pediatric epilepsy specialists where everyone who had a seizure can do that. But at this point, certainly if your child hasn't responded to the first medication they're given, it's time to think about seeing a pediatric epileptologist. And so that's just an important kind of thing. Epilepsy accounts for about 50% of all the patients child neurologists see, including both of these. So it is a very common diagnosis, and a lot of child neurologists are familiar with epilepsy. They see epilepsy a lot. But again, once you get past that first or second medication, that's where you need to think about a pediatric epilepsy specialist to kind of go through a lot of that workup that we talked about and some of those nuances about what's next. So you have a first seizure, you have maybe a second seizure, you're diagnosed with epilepsy. What do you do now? I think the important things to think about, right, are recognizing what a seizure is. That's often really difficult, right? If it's a tonic seizure or a tonic-clonic seizure, it's very apparent. If it's one of those seizures like an absence seizure or a complex partial focal with impaired awareness, it can be really tough to figure out what a seizure is and what a seizure isn't. Often we need EEGs to tell us or help guide us. So making sure you're aware of what your child's epilepsy or what their seizures look like is tough. It can be very challenging for both us and families, right? Videos have been a game changer. iPhones have been fantastic. Galaxies, whatever you have, taking a video of stuff and sending it, it's been game changers, right? So often we weren't able to, parents would try to describe it. Words are not the same as a video, right? We can only do so much. So we can only articulate things so well sometimes. Especially in the moment when you're seeing something like that, right? A seizure can be, it's a very stressful situation, and trying to say what you're seeing can be very difficult. Videos have really helped us. So if, you are seeing a seizure, you're not sure what something is, videos can be very helpful. There's some challenges with HIPAA, which is a way to protect patient safety and records, but you can always use a private YouTube account and upload that and send your link to somebody. That's a way to do it to get around that. It's important to kind of also think about how often are these seizures happening. So keeping a document, keeping a record, and we'll go through what different types of ways to do that. And then just being effective at communicating, right? Again, if you don't have the words for it, that's okay. I have a tough time describing things, right? The videos, very, very helpful. So if you can, great. It doesn't always work, right? Some seizures are pretty short. And again, communicating, documenting, observing can be quite difficult because of those subtleties of some seizures. Right? Absence seizures are often people will be oh, they're just not paying attention in class. Or focal seizures with impaired awareness, right? People would misdiagnose with ADHD, attention issues, anxiety, right? Not always it. Important thing too, when you're thinking about seizures and epilepsy, what are the triggers? Not everyone has triggers. There's some triggers that are very common for most people. Those include stress, whether that be a positive stress or a negative stress, right? Bad stresses certainly will cause your body to just be off, and that is going to make a seizure more likely. It actually makes any neurological problem more likely. So if you have migraines, stress is going to make that more likely to occur. Multiple sclerosis. Any neurological disorder, you're going to see stress be a major problem in making symptoms worse. Emotional stress. Missed medications, the nice thing why I do pediatrics, right? Parents are very good about making sure their kids take medications. Adults, we do our own thing sometimes, and we just, I don't know, I do it too. It's hard enough to take one multivitamin a day, and we're asking people to sometimes take medications 2-3 times a day. Sleep deprivation, pretty much for everyone as well. It's a stress on the body. So sleep deprivation, what it does is it's a stress, and it makes you more likely to get drowsy and fall asleep throughout the day. When you're going in and out, kind of drowsiness, that's when your brain's kind of syncing up. And so we were talking about neurons earlier. it's more likely for those neurons to kind of get recruited to those areas that are kind of having those spikes in drowsiness periods, because they're all kind of communicating and synchronizing up. So that's where sleep deprivation comes in. Illness also lowers your immune system. It's a stress on the body, so intercurrent illnesses. Interestingly enough, COVID did not have as much of an increase in seizures as we expected. Right now we're seeing a ton of different viruses. Just your regular childhood viruses kind of run rampant in schools right now that every kid is back. My nieces like to put their hands in my mouth when I'm not looking, right? And that's a surefire way to get sick, right? That's just what it is. And illness will make it more likely for your seizures to occur. Things we don't worry as much about in kids: alcohol, drugs also cause stress on the body. Missing meals. You might, if you have headaches or migraines, missing meals or not drinking enough water will make it more likely for you to have a headache. It happens with some kids too. And then there's particular stimuli that are pretty particular to different patients. Some flashing lights. Fortunately, in the environment now, we don't have the frequency of lights that are flashing that will typically occur for seizures. This happened, actually in Japan is really what triggered this. Pokemon. There was a Pokemon episode where the lights were flashing at a very high frequency, and it caused a lot of people in Japan who were watching it to have seizures. We then learned not to do that. And so that frequency of light really isn't allowed anymore. So when you do see that warning in movies, it's not like that frequency is high enough of what happened in the Pokemon kind of scenario, but it's just a trigger to say, okay, well, this could be stressful, just be careful. Hyperventilation. The reason we do this during EEGs is to try to, again, provoke those extra discharges or seizures, because it's another stress on the body. Some people, depending on the sound, that can be a trigger for them. Everyone's seizures are different, right? Depending on where in your brain that seizure is starting, there can be particular triggers. For some people, the phone sometimes, that noise can sometimes trigger it too. So, when we had not cell phones, but. So there's lots of different triggers. Some of them are quite unique to people. Lots of different treatment options. There's a bunch of talks today. If you look on your list here, I'm just giving you an introduction. But Dr. Sankar is talking about anti-seizure medications, rescue therapies. There's a whole smorgasbord today. This is sort of just an introduction to all of those. But anti-seizure medications, we think of the ones you take every day to prevent seizures, and then you have your rescue seizure medications, which are there to stop seizures in emergencies, which we'll get into. There's dietary therapies, ketogenic diet, low glycemic index therapy. Difficult in young kids, very easy because there's formulas. In older kids who are formula fed, it can be easy as well. In older kids, adults, it can be really hard. For a period, my brother thought he was on the ketogenic diet, but then he was at a Mexican restaurant drinking margaritas and eating nachos. That is not a ketogenic diet, right? Ketogenic diet, if you have a handful of blueberries, that's too much sugar. So, grain of salt. And, what you see on TV is not necessarily really the ketogenic diet. Surgery can be an option for people. We don't just take things out, we can put things in. So it really depends on the particular type of epilepsy. And that's where devices kind of come into play as well. Anything that's going to work on the brain is going to have side effects, has a potential for side effects, right? If we're going to say we're going to try to stop seizures in the brain, that medication is working in the brain, and 100% of the time has a potential for side effects in the brain, because that's where it's supposed to work. Most commonly, sedation or overactivity, right? So when you're thinking about seizures, two ways to kind of think about them, right? If you have, we're talking about electrical fires, but just conventional ones, and you have a fireplace, wood in the fireplace, cause it, fire's happening, you can either pour water on it, or you can take the wood away. Two options, right? And so depending on the medication and how it's working, if you're pouring water on it, that's basically like a sedative in a way, and that's going to tone down your electrical activity. If you take the wood away, it changes the way the fire's kind of moving around. And those are two big categories of medications. Again, biggest ones side effects we see, sedation, aggression. And those are just how the medications kind of work in the brain. Behavior and mood changes can be really hard to sort out, right? One of the most common side effects or comorbidities of epilepsy is anxiety. If you're diagnosed with epilepsy, and this is true for the patient and their families, right? If you or your loved one has a seizure and you have no idea when the next seizure is going to happen, the chances of you having anxiety is about 75% or more, right? We know that this is hugely problematic. In addition, the stigma associated with having epilepsy in adolescents, teenagers, is higher for kids with epilepsy than it is for kids with cancer or kids with AIDS. So just to give an idea of how problematic and difficult anxiety is, that it can be very difficult. So is this a medication side effect, or is this the anxiety that we really expect to happen with epilepsy occurring? and it can be really hard to tease out. And so when I was starting to talk about different things we think about when you're first getting started up with a seizure diagnosis, making sure that you're talking about mental health with your providers is really important. Not just for your patient, not just for your child, but also for yourself, right? It's a family unit. Your child may have anxiety, they may not, but you probably will, right? If you're talking about your child having something that you can't control, you have no idea when it's going to happen again, if and when, that's anxiety provoking. And so I think we're doing a better job now. In our center, we have a therapist now just for kids and a therapist for families, because we know divorce rates are super high in families with epilepsy, and it's a really important thing that we haven't addressed as much as we should, but we certainly are getting better at it. So it's an important thing to talk about. But this is why it's really hard for us sometimes when people are saying, well, my kid's getting aggressive. Is this the anxiety or depression that we know is going to happen with epilepsy, or is this the medication we're using? And so this is tough. We do know now that a lot of long-term side effects for these medications are pretty much not really there. But for some of the newer ones, if we've only used it for 10 years, we don't know what 30 years look like. For a lot of the medications, though, we do know that it's safe to use in babies as young as 1 day of life, and we know that 20, 30, 40, 50 years of therapy does not have issues. So what's intractable epilepsy, or medically refractory epilepsy? So this is a diagnosis we make when people have had 2 anti-seizure medications tried and they haven't worked. And they have to be the medications that are right for that particular person's type of epilepsy, right? So think of like a pneumonia, right? There's tons of different antibiotics. If I give you an antibiotic for a urinary tract infection and you have a pneumonia and it doesn't work, it's really not the antibiotic that failed, it's the person who gave it, right? So it has to be 2 medications that are really specific for your child's particular type of seizure and epilepsy. Refractory epilepsy occurs in about a third of people will be diagnosed with intractable epilepsy. So about 2/3 of people will respond to that first or second medication. About a third of people do not. You think that with all these new medications, that number would have gone down? It has not. What's happened is the side effects of medications have gone down. So with the newer medications, we see fewer side effects. Instead of taking it 3 times a day or 4 times a day, it may be once or twice a day. So the newer medications have certainly been helpful, but in terms of the patients who don't respond, they continue to not respond. Doesn't mean we shouldn't keep trying different medications, but this is where your pediatric epilepsy specialist comes in to really try and target a medication for your particular person or patient's child's epilepsy seizure type, EEG findings. Just another thing on the ketogenic diet, great, but again, you have to be careful. It's not a fad diet, the one that my brother thought he was on, right? You just have to be careful with it. There are side effects, but even though it's natural, it's important to just think about it. The ketogenic diet is super cool. We have no idea why it works. Some of the research I do is trying to figure that out. It's been used since biblical times. What it does is it mimics starvation. So in the Bible, people with seizures were actually starved. That was a way to treat seizures. It did help. The ketogenic diet is essentially tricking your brain into thinking it's starving. So instead of using sugar, it's using fat molecules. And so it's a switcheroo that we're doing on the brain. And those fat molecules, again, lots of different reasons why it may be helpful, and it's probably why it is so effective in some people, because it's not just working on one particular receptor, probably working on lots of them. If you or your child is on a dietary therapy, it's just very important to make sure they stick to it, right? If you give somebody a ton of sugar and they're on a ketogenic diet, that's essentially like cold turkeying a medication. Not very good. You also have to be very careful in schools. Schools are very difficult, right? Kids will exchange food all the time. So you just have to be very cognizant and explain to the teacher, the school nurse, everybody, not okay for, your child to trade sandwiches with somebody. Not okay. Just important things to think about. Yeah. Eats only food sent from home or approved by parent, right? That has been, it gets harder and harder as kids get older. Now, I think we all know this. Seizures can result in injuries, right? They can be life-threatening. Most of the time, they are not, right? So seizures, while they can be very problematic, interfere with your day, you can be off for a few days. The important thing to know is seizures will not typically cause any brain injury or permanent damage. What happens is the first chance for there to be any brain injury with a seizure, you have to be seizing for at least 30 minutes. When you're seizing, even though people may turn blue, your diaphragm is still moving. Your brain actually sucks out oxygen preferentially. Our brains have evolved to get oxygen out of the blood. So even when your muscles and your nails and your lips are turning blue, your brain is typically taking oxygen out. And so while your muscles aren't getting enough blood, your muscles can go without blood for 8 hours and you'll be fine, 48 hours. Your brain is taking all that oxygen out. So your brain preferentially will take that oxygen. So even if you see lips turning blue or finger events turning blue, your brain is typically getting the oxygen it needs. And so you need to be having a seizure where you're shaking for at least 30 minutes before there's even a chance of brain injury. How did we figure this out? Someone in 1978 took 20 different chimpanzees. They caused them to have seizures for 15 minutes, 30 minutes, 45 minutes, an hour, and they found that chimpanzees had to be seizing for at least 30 minutes before there was any chance of brain injury. Not all of the chimpanzees have brain injury at 30 minutes, but that was the first chance there was any. If you have a seizure where you're not shaking, we know that it probably takes at least an hour, but we don't know because that study wasn't done. So the reason why we say give a rescue medication after 3 minutes or 5 minutes is because if a seizure doesn't stop in 3 minutes or 5 minutes, it's less likely to stop on its own. Most seizures, 95% of seizures, will stop in less than 3 minutes. So if you see a seizure going on for 3 to 5 minutes and it doesn't stop, it's less likely to stop on its own. And we never even want to get to the point where a seizure can potentially cause brain injury. So that's why we use rescue medications. And there's a whole talk on the different types of rescue medications, so I'm not going to get too far into it. But important when you do have rescue medications, communicate with the school. If you have a vagal nerve stimulator, that magnet can act as a rescue therapy, so just important to make sure everyone in the school is also kind of informed about what's going on. And that kind of gets us to seizure action plans. Super important. Recent law in California was passed that allows school nurses we have to have them available so we can actually administer rescue medication if needed. Seizure action plans are fantastic because they allow physicians and schools to communicate directly with family input. So seizure action plans, really important. They're often templated now, so this is a fantastic thing that the Epilepsy Foundation did years ago, and now it's pretty much being adopted. Before, each school had a different kind of form. None of them kind of communicated with each other. They didn't always make sense. Now, most schools, you can give one of these forms from the Epilepsy Foundation, and they'll accept it. Especially public schools, private schools sometimes have their own, but for public schools, you pretty much can use this. And what this does is it gives an idea for the school, the teacher, and the nurse, what kind of seizures are we looking at, right? What are we going to do if we do see a seizure, right? Some people respond to one rescue medication, others don't, right? So there is a variation in how people respond to these rescue medications, and we can communicate to schools, teachers, and nurses with these kinds of forms. You should be involved in the planning process, right? So you should be involved in what's being put on there, right? Because this is your child. You need to make sure that the school and the nurses know what to look for. You need to be communicating and making sure those forms are up to date every year. It is annoying, right, having to update these, especially if things haven't changed. But the reason we do it is because things do often change, especially as kids kind of grow. And the last few minutes, really helpful too, is tracking seizures, right? When we're talking about is something working, is it not working? Are there side effects? Are there not side effects? Tracking this stuff can be very helpful. Memory and recall, I don't know about you guys, but I often have a tough time remembering what I did 2 days ago, or yesterday even sometimes. Memory and recall, not that great. Diaries and calendars are fantastic, but no one uses paper calendars really anymore. If they did, even when people did, they weren't super reliable because it's really dependent on what you're putting in, right? So seizure diaries, they can be fantastic. They don't cost really anything, but the reliability is really like what you put into it, right? And so it can be time consuming. And so we have busy days. Our days are getting busier and busier. And so this is, while helpful, it can be tough. And then if you're going to fill it out like once a week and you're trying to think back, and in some cases kids are having seizures multiple a day or multiple a week, they can be different. It can be very hard to kind of figure out what that is. Smartphone apps, a little bit easier. There's lots of different apps. I don't have a particular favorite one. Everyone's different, right? Everyone has like the way they want to do things. You can Google a bunch. You can download a bunch, see which one you like. They can be very helpful. They have some additional features as well. They can help with medication reminders for teenagers and adults. They have video things. And right now we're starting to link them to electronic medical records. So one thing in San Francisco that happened a few months ago is you can now link a particular seizure app into the electronic medical record. So every time we have a visit with somebody, we can see what you put into it, right? And again, you have to put it in, so it is that extra step of figuring that out. But we're getting to the point where we're actually able to start linking things and apps into our electronic medicine system, so you don't have to worry about showing me a figure on a Zoom call. What's cool is the newer sort of apps can kind of make these really cool graphs that we get excited about, but they're there. But they have challenges, right? It's what you put into it. The interfacing, I think this is kind of new. What we're doing in San Francisco is having this kind of link now, but it should be adopted more readily in the next couple of years. There are devices that can help track seizures. These are also wrought with difficulties. Typically, these are most helpful if you're having convulsive seizures, tonic or tonic-clonic seizures. You typically have to have a seizure where you're shaking for at least 45 seconds before a watch or other devices really pick up on that. You can imagine if you're a very active sleeper, I move around all the time, that watch would go off all the time. I've tried it just to, and it goes off a lot. So there's pluses and minuses to all of these things. But they are helpful in helping communicate. If you find a device that seems to really be accurate and helpful, that can be a really good way to help communicate with your provider and help understand what medications might be more helpful than others. So hopefully we reviewed some of these things. Hopefully this gives you an overview of what a lot of today is going to be, right? There's a lot of really cool talks that kind of go way into deeper detail about the things I talked about: surgery, anti-seizure medications. There's some pretty cool devices now to hopefully track absence seizures. Fortunately, there's some other things that are focusing on mental health. Again, things that we didn't really talk about very much, but PTSD, anxiety. We know that kids and families have these things, and they do need to be talked about. They're sometimes harder to treat than the seizures, right? Anxiety, depression, PTSD are tough. It's not just a pill, but it involves a lot of work. So thank you. And again, epilepsy is a team approach, not just providers, but families, educational liaisons, mental health providers, right? It's a group effort in these things. So it's just important to make sure you find your community, find where you need to be so that you can get kind of all the help you need. Thanks.
Adam, can I ask you a question?
Yeah, please.
So we're going to be with your team in 2 weeks with Ashe doing a medication vacation.
Right.
And so we're removing everything except for 2 medications.
Yeah.
And we've never done this before, and it's a little bit intimidating. Would you
Yeah.
recommend anything in particular? Dr. Singal and Dr.
Yeah.
Elliott are the ones still
Yeah.
doing this.
No, I mean, the benefit of something like that is in the hospital, right, we have access to IVs, which can really help. If there is something that happens, we can get it right away. The things with rescue medications is the intranasal forms, they can work, but getting from your nose to your blood system, takes a little bit of time. Whereas IVs, you can get it right in and you can stop it immediately. So it's just important that you make sure an IV is in place. But they'll do all that.
Thank you.
What's the app that you guys use at UCSF to help integrate?
Yeah, it's I don't know which app it is. What we do is we send out a link now, and then I have patients who are using it. It's really cool. It gives us these awesome graphs and tracks everything. But I don't know the particular name. But you can just ask your provider. It's the seizure tracker, and then they can give you an individualized link. So that way you don't have to worry about signing in or linking it yourself. It automatically is done that way. Yeah.
You're talking about medicines. If
Yeah.
you're trying to, how do you know that you're trying the right medicines? If the seizure's been misdiagnosed or something?
You don't, yeah. That's why you really have to, you don't. That's why, at that point, really making sure you're seeing a pediatric epilepsy specialist and one that, focuses on your particular child's type of epilepsy is important.
When you live in an area that doesn't have anybody other than one person,
Yeah.
or 200 miles,
Yeah. This is where Zoom has been really helpful. Again, so a lot of places are now allowing Zoom visits, and this is very common, right? There's entire states that have no providers, right? Idaho sometimes has one, sometimes it doesn't. Wyoming has one. We're in California. There's a ton on the coast, but once you go a little more inland, it's much more tough. And Nevada has like 2 child neurologists that come and go often. So it's hard for a lot of places. And so I think reaching out, you can ask people, can I do a Zoom-based visit? I see you're wearing a Tar Heels. So North Carolina, you have Duke. Depending on where you are, they have Zoom visits. UNC may. So just reach out to different people. No harm in asking. Well, thank you, everybody. I'll be around if questions do come up. Have a great day. There's an amazing set of talks today.